Infection control, we are one big happy family, but we do two distinct things. So infectious diseases are the infectious disease trained docs who really deal with the clinical diseases, and the infection control people, though, have a completely superlative area of knowledge beyond what we do. We know somewhat about infection control, but they're the ones that are the nitty-gritty of, like, what do we do with the patient? How do we isolate them? What should we do now? How do we track down everyone else that was exposed? So I would just want you guys to know that those are two different groups of people. We work integrally together, but they are definitely different. They have different pagers, different phone numbers, all that stuff. So we were both consulted, as we often are, at 5 o'clock on Friday or weekends or holidays, and airborne precautions were immediately instituted. And thankfully, because of that great history, the child remained isolated for the majority of their hospitalization, other than when they had come to the hospital. The specimens were obtained for testing, and ultimately the serum measles IgM was positive and IgG was negative, meaning M positive suggesting current infection, and G negative suggesting no existing immunity despite that history of vaccination. A nasopharyngeal swab for PCR looking specifically for virus was ultimately positive. And this child did well. The next day or two, the fever resolved, the conjunctivitis resolved, the rash resolved, and they went home. Okay, but the aftermath. Now, I am cramming this all in one very densely populated slide. This was 24/7 work by at least 30 people. Continuously doing this. So hundreds of exposed patients and families at the other institutions, because remember, this child had gone back and forth to multiple ERs, and we're not involved in that investigation. Working very closely, us and those hospitals, with the DC and Maryland Departments of Health. There were very carefully timed and worded joint press releases so that the community could be aware that this child had been out in the community, because obviously they were not just at the hospital, including public transportation. The Maryland EDs doing their own evaluations, but I wanted to give you an idea of what our infection control team does. So first you have to identify the exact route that this person took, and it's not enough to say, well, they showed up and they walked in the ER. You have to know exactly where they went. So we had people tracking down the exact transporter of this person on a weekend off hours to find their exact steps where they went. Once you know that, then we have to work with our construction team and get all the air ducts in the hospital and figure out which air ducts connect to those, wherever that person put their feet. And it's not just the air duct going up to the ceiling. So to make a very long story short, the entire, really, first floor of the hospital was considered an exposed airspace. And to make it worse, even though he was only there for 5 minutes, measles is so contagious, the air is considered contagious for 2 hours afterwards. So we now had basically the whole entire first floor, thankfully, on a Saturday morning, not on a Monday morning, exposed for 2 hours. And we worked very closely with all the unit directors and docs involved to get line listings of all patients, visitors, and staff that were in those areas in that 2-hour period. We had our occupational health team then looking at all the staff and confirming all of their vaccination, and that was 160 staff that had to be verified. And then we had 85 patients and families that we had to physically try to get a hold of by phone calls, letters, making sure that they knew this had happened and that we could document their whether or not they were susceptible or not. And almost half of them were susceptible because they were small infants who can't be vaccinated. And we'll come back to that at the end when we talk about the importance of maintaining very high vaccination levels in the community around these babies. We also instituted a Cerner electronic alert so that when of these people that are susceptible, we want to make sure that if they do come back to our hospital with symptoms, that there's an alert right away that we know this was an exposed person, and let's get them into isolation right away, not have another scenario where we have to do another outbreak investigation. And then on top of that, we had all the visitors who check in, at the desk. So we had to work with our security desk people who generated another line listing of yet another 150 patients. So I'm spending a little time on this just so you understand, and this was just a 5-minute walk through the ER and up to the floor. Imagine what's going on at the other centers where they had been there for hours and hours multiple times. So extremely contagious disease, and we don't want to kill our infection control people. So that's part of the take-home message is please always take a complete travel and exposure history, because early on in measles, that may be the only thing that tips you off that you should be thinking about measles and putting this person in isolation while you're sorting things out. Okay, so let's go over the clinical presentation. The incubation is 1 to 3 weeks. They typically begin 10 to 12 days after exposure. This child, they said about 8 days after exposure. The rash comes about 3 days after the symptoms start. And this is one of the hallmarks, as Dr. Wiederman points out frequently when we're teaching our fellows, that may separate it from some of the other viral illnesses that have fever and rash, where the fever and rash often come together, or for instance in roseola where the rash comes after the fever. So with measles, you have the fever first, and then on the 3rd day of fever, while you still have fever, you start to get a rash that will start from the head and move down. And I'm going to show you, I'm going to say it in words, I'm going to show you pictures, and I'm going to show you a video. You can kind of burn that into your mind. You're contagious, unfortunately, 4 days before the rash. So that child, when they were going to these ERs without the rash, still was very contagious. And you remain contagious until 4 days after the rash appears. The prodrome before the rash is called the 3 C's. So you have a stepwise increasing fever, and the 3 C's are cough, coryza, which just means runny nose or rhinorrhea, and conjunctivitis. And this will last, as I said, 2 to 4 days before the rash starts. If you're lucky, you may see Koplik spots in the mouth at this point, and I'll show you a picture of that. And then that rash. So it's a maculopapular, meaning you can feel it, raised rash. It starts, we call it a top-down rash, meaning it starts on the face or head usually, then moves down to the trunk, and then on the lower extremities as well as the palms and soles. Some people don't get a rash, but the vast majority of people will have a rash. And there are multiple complications, which we're going to talk about after I show you some of these pictures. So this is the initial facial rash. It's showing you how it becomes coalescent. This is in an Asian child. And there's another slide I'll show you where there's a darker skinned child where it may not be as red. It may just be more papular and hyperpigmented. This is an example of the conjunctivitis and the rhinorrhea or coryza. Yet another child here. This is the morbilliform rash. So, you know, there's nothing specifically about this rash that would be completely different than Kawasaki. It's a maculopapular rash. But what's different is the history. So that's why I'm saying the history is really important. Not only the history of how the rash started and how it moved, but how it was accompanied with these other very prominent respiratory runny nose cough symptoms, which you typically would not have in the case of Kawasaki disease. And then here's an example of the rash I was describing in a darker skinned child. So these are the Koplik spots. They're apparently very hard to see. I've never seen Koplik spots, and I've actually never seen a case of measles. I didn't get to see this child. So those of you who did, you can correct us if we're wrong here on the slides. But these are characteristic white lesions on an erythematous margin. Here they are, these little tiny white spots. And here they are again on the buccal mucosa. So this is pathognomonic, apparently, for measles, if you're lucky enough to see it. So I really think this is a helpful video. It takes about 2
The clinical features of measles are fairly distinct, at least after the rash appears. Unfortunately, most of the transmission takes place before the rash appears. After an incubation period of 10 to 12 days, there is a stepwise increase in temperature to 103 degrees Fahrenheit or higher. What usually follows is the classic triad of cough, coryza, or runny nose, and conjunctivitis, or pink eye. An astute observer may see Koplik spots, a rash found on mucous membranes, a day or 2 before the cutaneous rash. This prodrome usually lasts 2 to 4 days. The rash appears about 14 days after exposure and is caused by deposits of measles antibody in the skin. The rash is maculopapular and appears first on the face.
Like it decided to stop.
During the next 2 or 3 days, it descends to the trunk and then to the arms and legs. The rash fades in the order of appearance. You may have seen measles when it was more common in the late 1980s and early 1990s. For those of you who have not seen it, here's a visual aid.
This is a child with measles prodrome. Measles prodrome usually produces a moderate illness. Notice the coryza, or runny nose, and her red, teary eyes indicative of conjunctivitis. This is measles at about 2 days into the rash, or 5 to 6 days into the illness. The rash is maculopapular and demonstrates coalescence when the discrete macules combine into larger red skin lesions. Cough is almost universal with measles. The rash is typically most intense on the head and upper chest, but is usually present on the lower chest and arms. This is a dark-skinned child with measles. The child has conjunctivitis and coryza. The rash is papular or raised, not flat. A measles rash is more difficult to see with dark skin. If the rash is accompanied by other symptoms such as cough or conjunctivitis, measles is easier to diagnose.
Okay. So I think that helps to actually see a live person with that, and we could put the lights up again if that's possible. So there are other, we talked about Kawasaki disease. Scarlet fever can also present with fever and rash, but again, typically does not have this extensive coryza, cough, and top-down rash. We talked about Kawasaki, how it differs. There are many viral xanthams, but again, this classic top to bottom with the delayed onset of the rash while the fever is still there is a typical, quote, script, as Mary has taught me to say, for measles that you should be aware of and put it in your library, in your brain. So complications can be severe. Pneumonia, encephalitis, and death can occur. The numbers are actually pretty shocking, and I'll share with you the numbers before we vaccinated on the next slide, but 1 in 4 people who get measles will end up hospitalized. 1 in 1,000 will develop encephalitis, and 1/4 of those with encephalitis will have significant neurodevelopmental sequelae. 1 in 2 in 1,000 will die. And there's also a very rare condition called subacute sclerosing panencephalitis, which presents much later, 10 years after a patient has had measles, and it's a degenerative disease. The highest risks for these severe complications and hospitalization are children under 5 years of age, adults over 20 years of age, our pregnant women, and our immunocompromised population. So if you suspect it, if you're in the hospital, you call us and we're going to help you. If you're out in the community, you want to pick up the phone, and we're certainly happy to help you as well, but you want to get in touch with your health department right away, not only just for reporting, but they're the ones that are going to help you sort through what to do about the case. And they're going to be your friend in finding all the potential contacts because they take over that duty. You become responsible for that patient. They will take over the duty of the rest of the community exposure and the outbreak investigation. The detection is for, we use serum specimens for IgM antibody, and we also use direct detection by RT-PCR, as we did in this case, on throat or nasopharyngeal swab. It can also be isolated from urine, and in some cases we'll do a combination of urine and nasopharyngeal swab. Now, IgM antibodies are, as you know, in this disease and many others, not the most reliable test. If we get a positive and it's in a clinically consistent case, then we believe it, but false positive IgMs can occur. And more importantly, false negative IgMs can occur, particularly if it is obtained, the specimen is obtained in the first couple of days that the rash occurs. So if you really clinically suspect it, don't say, oh, it's not measles because the IgM is negative. Really, the PCR is the better test. All right, so transmission occurs by direct contact with infectious droplets or airborne spread. So I've already told you about the havoc that's wreaked when someone walks through a space because that air is highly contaminated. It can remain infectious on surfaces and in the air for that prolonged period we talked about, and it's highly contagious. So 9 out of 10 exposed non-immune individuals will be infected, even if they've only been exposed to the air that that person was in contact with. And of course, it's going to depend on how infectious that person was when they were walking through the facility. So we were somewhat lucky in this case, I think, knock on wood. We're not quite out of the 21-day incubation period where a secondary case could present. But this child came to us relatively late in their course. They had already been at various places and were now, already had rash for several days. And in fact, effervesced and improved, by the time the next day that they got to our hospital. He also had some vaccination, so we think that perhaps that may have limited his infectivity to other people. So you always use airborne precautions before you examine a patient with possible measles. And this is even true if you are an immune provider. And in fact, if you're not an immune provider, you should not examine them at all, not even with an N95 mask. But if you are immune, which all of us hopefully are at Children's, it's a requirement, and we'll make sure, unless there's a reason that you could not be vaccinated, but you should know that you're immune. And I would suggest that all of you make sure that you have documented your immunity, because things can happen where things slip through the cracks. So for your own personal safety, see if you can make sure that you've been vaccinated appropriately. And then if you are immune, you still need to wear that N95 mask. We get asked that sometimes. Well, why do I need the mask if I'm vaccinated? If you're in your office for any possible case, if you have negative pressure, great. But if you don't, at a minimum, you want to put them in a private room, close the door, and put a standard mask on the patient, not an N95, a standard mask to prevent the droplets from coming outward. Immediately, again, notify us in the Department of Health. This is what we consider evidence of immunity for a healthcare provider, not just us, but the CDC. So documented 2 doses of vaccine, or serologic evidence of immunity, or lab-confirmed infection when you were younger for some of our healthcare providers who lived in an era where before the vaccine existed. But one thing that we get asked frequently is, if I was born before 1957, do I have to get vaccinated? And the current state of the art is we need to at least document your serologic immunity if you were born before 1957, if you're a healthcare worker. We don't just say, oh, you were born before 1957, no problem. And the reason for that is that there have been cases of healthcare-associated cases in individuals born before 1957 who just did not have protective immunity. Post-exposure prophylaxis. So one of the reasons that when we have a case, we don't say, well, let's just wait till, it's convenient on Tuesday to assemble the large group to start trying to find people. And the reason is we have a very short period that we can intervene for those that we identify who are indeed susceptible. Now, in the case that we had, that we were already on the last day that we could possibly give immune globulin to any identified susceptible individual. But in most cases, we'll know it sooner, and we want to get on it right away so that we can get within this 72-hour window where we can actually give vaccines to people who are old enough to try to prevent them from getting disease. We also use measles vaccination in children as young as 6 months if we're in an outbreak situation. So in other words, let's say there were a bunch of secondary cases from this child who was out in the community. At that point, we would lower the age at which we would give vaccination as a possible intervention. But right now, with a single case, we still would not vaccinate someone until they're at the standard age. If you're a healthcare worker, we exclude from duty from day 5 to 21 after exposure if the person is susceptible, even if they get the vaccine. Now, immunoglobulin we can use for a longer period, so that's 6 days after exposure. And this is for the people who cannot get the vaccine. So if they're too young, if they're pregnant, or if they're immunocompromised, it's not safe to give the vaccine because it's a live vaccine. So the same principles for live vaccine apply here. We don't use immune globulin to try to control an outbreak. It's really specifically to try to prevent that exposed, susceptible, and vulnerable person from getting severe disease. And we do not let healthcare workers, again, go back if they are in this situation until that 21-day period is up. All right, so elimination. If you look at how many cases of measles we had before we instituted live measles vaccine in 1963, look at these numbers. Every year in the U.S., there were 3 to 4 million people. I mean, these are huge numbers of cases. And I think even my generation, we just can't believe this. Like, we've just never seen a measles case. So it's hard. There's no memory in my mind of the era when, I was a doctor taking care of these kids coming in with measles. But there are people in the audience who do remember this, and it's a real phenomenon that it's our duty to make sure our friends, colleagues, everyone knows that this really happened. It's not something that's theoretical. There were 550,000 lab-confirmed cases each year, but of course there were many more that were not reported. And every year, look at this, nearly 50,000 hospitalized people, 4,000 cases of encephalitis, 1,000 chronic disability from encephalitis, 500 deaths. you know, if this happened now, people would be up in arms, and we have a vaccine that can prevent this to a great extent. And it's a worldwide problem that still is going on. So even though we feel that we're somewhat safe here in the U.S., you know, since 2000 when we declared it eliminated, I'm going to show you now some pictures of how many cases we've had since we thought we eradicated it. And why is this happening? It's because we have pockets of declining immunization rates. So I'll show you that, you know, if someone quotes the U.S. vaccination rates, they look pretty good. But the problem is if you have at the county level or the state level pockets of unimmunized people, even though the global national number looks great, that's where the problems happen, and that's where these cases can spread like wildfire. Another reason is that we travel a lot more than we used to, and we go to Europe routinely, you know, where there is rampant cases of measles still going on in France, Germany, and I'll show you a map of that too. And it's still common in the rest of the world. So 20 million cases and 150,000 deaths each year. So measles can enter very easily. This is a slide that Netta Harik put together, and she actually gave a similar lecture to our community physicians last week in the middle of all this, so we could really educate people to be on the lookout. And I think in the news sometimes people harp on, oh, you know, it must have been someone coming from another country that brought the measles. Well, actually often it's us going to visit another country and then coming back and bringing it into our country. So, for instance, France, Germany, Switzerland, Italy, these are top destinations, for me included, and for many people in the U.S. to go on vacation if they can afford it. And they'll go and bring their children and not even think about the fact that they are potentially exposing themselves and their children to measles. But they may be unvaccinated if they have concerns about MMR vaccination. So this is a graph of the number of U.S. measles cases by year. And you can see that every year there's 50 to 150, 200 cases. And then in 2014, there was a huge number of cases. And I'll go into a couple slides on the reason for that. We've dropped down again now, but in 2016, as you can see, there were 70 cases in 60 states, and in 2017, we've had 61 cases already. So we're by no means have we eradicated this problem, and we should be on the lookout for these cases as they can occur. So this is very wordy, but I think it's important to look at why do the vaccination rates decline. It's not like people just say, well, I don't want to vaccinate. There are triggers for why people decide that they don't want to vaccinate. So in the late 80s, there were pockets within the U.S. that led to this resurgence, and we had lots of hospitalizations and deaths. And then there was a campaign to make people aware of this disease and to vaccinate. Well, as you all know, in 1998 in the UK, there were false claims that the MMR vaccine caused autism. And it took a very long time, as you know, to get that word out, not only within the scientific world, where all the authors retracted their, you guys have heard that story 100 million times, but that memory of that claim existed in the population for a much longer period of time. And in fact, the immunization rates dropped down to 80% and low enough in 2008 to allow this return of endemic measles in the UK. If we look at 2001 to 2008 in the U.S., we had this total of 600 cases and this kind of baseline 35 to 150 cases per year. And when we drilled down to see why those cases were occurring, it really was not increased importation from other countries, which is, you'll hear this frequently in when you talk to your at cocktail parties with people, or if you talk to the press even, they'll ask you, you know, isn't it because there's more people coming from other countries? No, that is not the reason why. The reason is that there's refusal to vaccinate and these pockets of decreased herd immunity that then allow an introduced case to spread. And then, as you know, in 2014, we had a record number of cases, and then 2015, when I talked to you last about this, we had the giant Disney World outbreak. And we think this started from a traveler who became infected overseas with measles, so a U.S. citizen went overseas, traveled, came back. But this led to 115 secondary cases just in that amusement park exposure. And the vast majority of those secondary cases after the exposure investigation was completed were in unvaccinated or incompletely vaccinated individuals. This is just a picture of that outbreak showing you that, yes, the bulk of the cases were in Disneyland, but then these patients went back to their states because, you know, people come from all over the place to go to Disneyland, and there were secondary cases in 6 other states as far Midwest as Nebraska. So if there are pockets of under-immunized people, the disease can spread outside of the original area. And in fact, you've probably been following in the news here in May, there's a current outbreak going on in Minnesota. If we look at the vaccination rate in the population that seems to be most affected, this has been in Somali children. And if we look at the vaccination rate between 2004 and 2014 in the non-Somali non-Somali population, it's remained around 88 to 89%. But in the Somali population, it's declined from 92 to 42%. So that accounts for why we're seeing that resurgence in Minnesota. So this is an incredibly efficacious vaccine. It comes in MMR and MMRV. There is not a single antigen measles vaccine available. So during that era where there was a lot of hysteria about the MMR causing autism, there was a push that people didn't want the MMR at all, or they wanted to go find a single measles preparation. But the message you should be giving your patients and your friends and other people is that the MMR and the MMRV are safe. They are not linked to autism. Even the autism groups are very outspoken about this because they want to move on and actually find the causes of autism, which are not the MMR vaccine. And that we are not going to be subscribing to giving small or single doses of vaccines to separate exposure for various antigens. One single dose is 95% effective, but the opposite of that is 5% do have a primary failure to make an immune response to the vaccine. So the second dose, the reason we give that second dose is not so much the concept of boosting immunity, but to get a higher chance of someone actually getting a take. We're really targeting that 5% who don't make the primary response. And with that second dose, we are 99% effective. So almost all of these non-responders, meaning that 4% of that 5% will then go on and have a protective response after 2 vaccines. Okay, so I'm going to just pause a little bit here because I was also asked to talk about another case, and then we'll come back to the common thread between these 2 cases. So this was a 15-year-old male, and I have to thank Dr. Teach for sharing these slides, which I modified to simplify for this. This case was much more complex, and his slides were much more beautiful than mine. But this gives you the punchline. So this was a 15-year-old male who presented to primary care with painful swelling in the upper anterior left neck for 2 to 3 days and a fever for 1 day. He remained at home, really wasn't that sick, had some intermittent fever, a little bit of, neck swelling that was tender, some body aches. But then the reason he came back to care was he had swelling in his groin region that was consistent with bilateral orchitis. And at that point, someone said, swelling on my face and orchitis, there's not that many things that do that, and the issue of mumps came up. So a diagnostic test was obtained. The patient did go home, and they got better, and history was obtained, and this child actually had not had MMR vaccination for some valid reason. But the mumps IgM was positive. The mumps IgG was also positive. And at this point, the child was so late into the illness that the PCR could not confirm the diagnosis. But it's well known that the PCR will be negative if we wait too long. So this was a clinically compatible case of mumps here at Children's. So this is the same family of viruses as measles, and it's also highly infectious. It is not, however, one of the viruses that is spread by airborne route. It's droplet route, so you do not need a negative pressure room for mumps. It typically involves one of the parotids, and it can be bilateral, however. And some of the cases are completely asymptomatic, which, of course, we're not going to detect. And there are multiple complications, including orchitis and mastitis oophoриtis. This is a graph of the mumps cases by year that Dr. Teach put together, and again shows you, similar to the measles story, that there are spikes. But look at the numbers here. We're talking thousands of cases. So here in 2016, there were 5,500 cases, and in 2017 already, there have been 2,000 cases a month. So this is another disease that really exists. It's really out there. It's really in the U.S. And this is a graph showing you the density of cases across the U.S. So the darker the number, the higher the number of cases. So this is this dark color is 300 plus cases. So even around here in Pennsylvania, New York, there are many cases. If we look here at Delaware, Maryland, D.C., we have fewer numbers, but it's not zero, including at our own hospital. And I love this slide Dr. Teach put in. The NHL, if you've been reading in the paper, there's been resurgence of mumps because you can imagine they're in very close contact, lots of secretions going back and forth. So there have been little pockets of mumps outbreaks in the National Hockey League that are being dealt with on top of all the college campuses that you hear about. So one of the diagnostic pearls for mumps is that, and actually for parotitis in general, to distinguish it from the script that you know for adenitis or lymphadenitis, is that the parotid can be distinguished by more well-defined borders, the lymph nodes can be characterized by more well-defined borders, so you can discreetly feel around the area of lymph node enlargement, or it gets a little more difficult if you have a bunch of matted nodes, but in general you can really kind of get your hands around it. And you can usually still see the angle of the jaw because there aren't many lymph nodes right over that angle of the jaw. They're kind of below or above. So if you have a parotid enlargement or parotitis, you tend to have just more diffusely ill-defined swelling, and it may actually obscure the angle of the jaw. So that's the classic pearl for distinguishing parotitis from adenitis. Now, parotitis has many, many causes. Bacterial is much more of an acute, abrupt illness, typically caused by staph or other oral anaerobes and aerobes, and it's usually a very sudden onset, severe pain, erythema. If you look in and look in stents and ducts, you may see pus coming out. So that's different than the presentation of mumps. Mumps is much more, a little bit indolent, really not this acute, highly febrile, ill-appearing person. The non-bacterial causes include mumps, but all of these other viruses can cause it, and honestly, it's very difficult to tell them apart. So really, again, what is going to help you? History. So you've got to take a history and find out if this person is vaccinated. If they've had 2 vaccines, it's really unlikely that it's mumps. Not zero, but if you, on the other hand, if you get a history that they're not vaccinated, or they've only had inappropriate or incomplete vaccination, you should move mumps much higher up on your list if they fit that subacute presentation. And of course, there are many other non-infectious causes which are beyond the scope of this discussion. So the mumps vaccine is also efficacious, but not as efficacious as measles. So you need to be aware that even with 2 doses, you know, it's not 99%, it's 90%. And 1 dose, though, is much less efficacious. So that's why in the setting of these outbreaks and in college campuses and the NHL, we want to make sure that everyone has had the 2 doses of vaccine. Okay, so I'm going to end here on something that brings the measles and the mumps cases together. So far what you should take home is these cases really exist. The disease is still here. It's still very prevalent in other parts of the world. We travel back and forth. We bring it here. So the only way we're going to prevent cases from spreading here in the U.S. are by vaccinating, okay? So how are we doing with vaccines? I think most of you are familiar with the concept of herd immunity, but it's really not the individuals who are at risk, not just the unimmunized individuals who are at risk. It's the whole community when we don't vaccinate. Vaccinated people act as a barrier to disease for the community, reducing the risk of infection for people who cannot be immunized. So a lot of people say, well, you know, if they're not vaccinated, they're choosing to get the disease. Well, they're actually not just choosing for themselves. They're choosing for infants who can't be vaccinated, pregnant women who can't be vaccinated, immunocompromised people who may or not make a response to vaccination. So it really is not just making a choice for the individual when you decide not to vaccinate. Overall, our rates against measles and actually mumps have been stable since the Vaccine for Children program was introduced in 1994. And if you look at our overall national coverage rate for MMR in the children 19 to 35 months of age, for which this is typically done, this survey, it was 94%, which sounds great, right? Why do we have a problem? But if you look down at the county and state levels, there are many pockets, and I'm going to show you a map of that. So if we look at the estimated vaccination coverage overall, so this is not just for measles, mumps, and rubella, but looking at all the standard vaccines, for children up to this age. You can see that there are many areas that are white, which are bad. That's 87 to 90% vaccination rate. Look at these states that have really poor coverage. 91 to 93% in the light colors. So here we are on the East Coast, and we're in the higher realm, but it's really not great everywhere, even though our overall national number is touted at 95%. And then when we look specifically at MMR, which I told you had all of that overlay of, autism and concern and people worrying about it, even the people that believe in vaccinations in general, there's a much larger people that still have these concerns about MMR and don't want to give it to their children. So now if we go back to this map, you see there's lots of dark blue. There is white, so lots of dark blue. Now look here, we've got tons of white and tons of light blue. So we are still not doing a great job of getting all of our children in the U.S. Fully vaccinated. If we look more closely, this is data up through 2013 at our particular area. The District of Columbia actually does pretty well, and so does Maryland. But look at West Virginia and Virginia. These are our next door neighbors, and it's not that great. So we have a long way to go to eliminate this possibility of herd immunity disappearing in our region. This slide I like to put in because, again, it is not, you cannot predict who's not vaccinated by race, by poverty level. It is really across the board. So it doesn't matter if, and in fact, in some areas of the country, it's the educated and higher socioeconomic classes that are not vaccinating. So we want to dispel the myth that it's, just ignorance or people that don't have access to get vaccinated. It's really not, that is not the driving force for why we don't have vaccination in the U.S. And in fact, declination and exemptions are a major problem and a major target of the Infectious Disease Society of America, the Pediatric Infectious Disease Society, and many other pediatric advocacy agencies, including our very own group here, led by Tanya Kinlow. So this is a quote from Jane Seward from the CDC. The problem is people not getting vaccinated. The vast majority of cases every single year are people who choose not to be vaccinated. They are living in a family who are unvaccinated. They have friends who are unvaccinated. They may go to a school with a high proportion of people who are unvaccinated. And look at these numbers. In California, 8% of kindergartners have exemptions for measles vaccination. In some California schools, the exemption rate is as high as 43%. I mean, we know that 43% is not medical or religious reasons. There are different reasons why people are declining, and if it's not legislatively mandated to not allow these, just I don't feel like being vaccinated, then this is what happens in these pockets. And I'm not going to go into all the risks, but the risk of getting measles among the exemptors is very high and is a major problem. This is a really nice slide. It's not fully updated yet to current, but I think the point here is it's overlaying the rate of exemptions in a state with the rate of actual cases, of MMR coverage. So if you look at, for instance, any state that has a hash bar means that they have coverage that's less than 90%. And then if you look, the darker the color, the higher the number of exemptions. So these dark states that the states that are allowing the exemptions are the ones that have lower rates of immunization. It's a direct link. So it's not something that's theoretical. It's been proven. So what are we doing here and what's being done in the U.S.? We are trying, we meaning the entire infectious disease division, the entire infection control division, our ED colleagues, the primary care providers, our advocacy groups. We're trying to educate the community and all healthcare providers not only to recognize measles and appropriately isolate, but to be an advocate amongst your peers about the safety and efficacy and necessity of giving these vaccines. We're also working really closely with occupational health to make sure that we have good compliance and good documentation of measles, because we're lucky at our hospital when we have these outbreaks and we heard that there's 160 staff that were on duty that day. Well, we knew immediately that probably 159.9 of those were vaccinated, just because we've done the pre-work to make sure that compliance occurs. She's shaking her head saying, maybe it's not 159.9. But the vast majority are, and that's different if you work at an institution where there's not a mandate to have the vaccination done. We're also partnering with our community and government leaders. So I've gone to the Hill and talked about declination and explaining to them in layman's terms why it's important for them to not allow the random ability to decline vaccines. And then we get asked frequently by the media to comment on this, and we are always happy to do it on behalf of kids. So, and you should do the same, and we're happy to help anyone who needs data if you get approached, and work closely with our PR division, who is expert at sorting out really good opportunities for us to get this message out. So what can you do personally? Ensure all patients are up to date on their MMR vaccine. You should ask them that every time you see them. Screen at your office for fever and rash illnesses. Consider measles or mumps, but we talked more about measles today. And anyone with a febrile rash illness and that clinically compatible 3 Cs, particularly if your history, which I know you're always going to take a detailed travel and exposure and immunization history, brings up that they recently traveled abroad or had contact with someone with a febrile illness, which is exactly was the case with our patient here. Isolate immediately, call us, call the health department, and be an advocate with your friends, family members, and coworkers. So we have many resources here at Children's, both on the intranet and the internet for our patients that you can point them towards. And I think I'll end there. We don't have a lot of time for questions, but I'm happy to take any, and you guys always know how to reach us if you have other questions.
Exemptions in D.C., Maryland, and Virginia.
We have we don't have many exemptions in D.C. I don't know the details of the exemptions in Virginia, but what I'm saying is that there's a legitimate reason for exemption if you have a medical reason that you can't be vaccinated. Yeah, but in some states like California, you can just say, I don't believe in it, and you can sign a piece of paper and still bring your child to school. No, not that I'm aware of. Yeah. Bud, you want to comment?
Well, I believe there are non-medical exemptions everywhere. There are non-medical exemptions everywhere, but the states differ in how difficult it is to obtain that, how much paperwork you have to fill out. So actually there have been studies looking at that paperwork and then the rate of declination in various states, and it correlates very well with that.
So meaning the harder it is to get the exemption,
right, if you have to fill out 3 forms and wait 2 weeks or something like that, you know, you're not as likely to follow through. So I think a lot of the push is to, you know, make it at least as hard to decline an immunization as, you know, applying for driver's license or something.
Just two quick questions. Roberta, can you remind us of the risk of measles in pregnancy? Is it primarily a risk to the mom or the fetus? Is there a congenital measles syndrome? The second one is, can you remind us of the association, which I know is very important in the third world? I'm not sure it's been well described here, between vitamin A deficiency and measles morbidity.
Yes. So the first question was about pregnancy. There's a higher rate of severe disease in general for the mother, so a higher rate of pneumonia, encephalitis, so severe disease as described for the babies, etc. And there is a higher rate of pregnancy loss. And I believe it's primarily in the first trimester. Bud may be more knowledgeable than I, because we just don't see this as a consult too much anymore. But to my knowledge, the main risk is actually loss, not so much that there's a known, syndrome associated with measles. So would you agree with that? Yeah. And then the vitamin A point is, in developing countries where there isn't as good nutrition here, it's true that vitamin A deficiency is correlated with more severe disease. So in fact, there was recommendations to supplement all kids with measles with vitamin A supplementation as well in developing countries. But we don't do that here, do we?
Well, sort of, data are limited, but in general, children
Yes.
Your measles is to have those five things. Probably the risk of
severe. Does that answer your question? Yeah.
Hi, I'm Annie, one of the pediatric residents. I had a question about, we recently admitted a patient for suspicion of measles, meeting some of the clinical criteria, but had been immunized. And my question is, does the classic script sort of change in the face of immunizations that were improperly timed or just receiving one? Do they not quite fit all the clinical criteria, number one? And number two, if the patient is otherwise, well hydrated and stable, can we just send them home on isolation and send some labs and feel comfortable with that decision?
Okay, my first question is, you did tell us about that patient, right?
Yes.
Okay, good. Okay, I saw Cheyenne was starting to get a little cagey there. Yeah, so the first step is, of course, call us. We're going to help. But you're right. So if you have partial immunization or full immunization, it can ameliorate the disease. So it may not be the typical script. And in fact, emesis is not typically, what we consider the measles illness script. So I think that was part of the confusion, when this child was seen earlier. That was really one of the more prominent parts of their initial part of their illness. In vaccinated individuals, there may be less rash or shorter duration of rash. And in fact, Netta, who saw this patient, did you feel that the duration of the rash was lower? Yeah. There's a question, I think, from the... Oh, okay. Yeah.
Can you just repeat that again?
Yeah, so Netta was just talking about that there can be an atypical measles syndrome we were talking about patients who have been vaccinated, so they may not have as prominent a rash and it's shorter duration. Yeah. Yes.
A quick question about SSBE. Does it just follow wild virus infection, or is there any association with having had immunization?
Oh, that's a good question. So could you have a case of SSBE associated with vaccination? I have to be honest, I am not well-versed in SSBE, and again, Bud may have more knowledge, but I do know there have been vaccine-associated cases. Yes.
So back in the old days, it was thought that the rate of subacute sclerosing panencephalitis following measles immunization was about 1 in 4 million. Nowadays, and obviously that's very rare. Nowadays, the current thinking is it probably doesn't happen related to immunization, but I think you said about 1 in a million following natural disease. That's, as Dr. Weinstein knows, a very distinct disease and very distinct EEG finding.
Okay. I think we'll end there. And again, if you have other questions, please call us anytime. And definitely call us if it even crosses your mind that you have a measles or mumps case. Call us right away. Thanks a lot.